Good afternoon, everyone, and welcome to this afternoon's webinar. My name is Dave Greenwald. We'll be starting in approximately 2 minutes. Please hang on. Good afternoon, everyone, and welcome to this afternoon's webinar. My name is Dave Greenwald, and I'm the co-chair of the National Colorectal Cancer Roundtable's Public Awareness Group. Once again, thank you all for joining. We've had an incredible response to this webinar, and it thrills me to see the momentum around the 80 by 18 in action. So why are we here today? Actually, we have just over 400 people listening in. The response, as I said, has been just crazy good. The purpose of this webinar is to introduce all of you to a new resource of the American Cancer Society and the National Colorectal Cancer Roundtable, the 80 by 2018 Communications Guidebook Effective Messaging to Reach the Unscreened. So this resource, which can be found on the Roundtable's website, is based on new market research from the American Cancer Society with guidance from the National Colorectal Cancer Roundtable's Public Awareness Task Group. So why the research and why the new guidebook? Well, it's to answer the key question, how are the unscreened different from those who have already been screened, and what will it take to move the unscreened to action? So with that focus in mind, the Communications Guidebook, which I might add is awesome, is designed to help educate, empower, and mobilize 3 key audiences who are not getting screened for colorectal cancer. And those key audiences would be, number 1, the newly insured, number 2, the insured but what we call procrastinator/rationalizer, and number 3, the financially challenged. So the webinar today will review the research that served as the foundation for the guidebook, introduce participants to new tested messages for reaching those audiences, and then highlight where to go in the guidebook to learn about these hard-to-persuade groups. We are also pleased to share with you some new infographics, banner ads, and social media messaging that you can use. A really important caveat, having said that before we get started, and again, this is key because we have so many groups on the call, represented on the call today. The resources in the guidebook are not intended to replace any partner's outreach effort around colorectal cancer screening, but rather we hope these resources will supplement your current efforts and magnify our collective voice, our one voice, with these crucial audiences. Here's what's going to happen during today's call. First, you'll hear from Dr. Richard Wender, who's the chair of the National Colorectal Cancer Roundtable and the Chief Cancer Control Officer of the American Cancer Society. Dr. Wender will start off the call by explaining how this work fits into the overall strategic effort to achieve an 80% screening rate by 2018. Dr. Wender will be followed by Angela Hayes, who's the Managing Director for Mission Support Communications, and Angela will walk participants through the new research, the guidebook, and the new tools that will be available to you. We will close by hearing from a number of colleagues who will share very brief examples of how they are taking the research and using it in their own exciting and diverse ways and efforts. So who will we hear from? We'll hear from Michael Sapienza, who's the president and founder of CRISPR Life, Audrey Von Kirk-Villalobos, who is the director of the Comprehensive Cancer Control Group at George Washington Cancer Institute, Christy Marcel from the State Health Systems of the American Cancer Society, and Angie Davis, who's president of Fight Colorectal Cancer and my co-chair of the NCCRT's Public Awareness Task Group. We hope these examples will help you think of ways that you can use the new messages and research in your own creative ways. A couple of housekeeping issues before we get started. First, we're recording today's webinar, and the replay will be shared with all of you if you want to listen to it again or refer it to others. We are asking for your help in evaluating the webinar. You'll be receiving an email with a survey link. Please help us out with feedback, and specific feedback is always better than general feedback. Number 3, because we have a large number of participants, now up to almost 500, all participants are muted on the call. Having said that, we still want to make sure that you get what you need out of the webinar. So we encourage you to ask questions by submitting them through the webinar. You'll see a Q&A box on the lower right-hand corner of the screen that you're looking at. We will also save time for questions at the end, and you can always email us afterwards as well. Finally, number 4, we will resend the link to all of you after this call so you can download these tools and use them in your colorectal cancer control efforts. So with that, now I'm pleased to introduce our first speaker, Dr. Richard Wender, as I said, Chair of the National Colorectal Cancer Roundtable and Chief Cancer Control Officer of the American Cancer Society. And Rich is going to explain to us how this work fits into our overall strategic effort to achieve 80% by 2018. Rich, take it away.
Thanks, Dave. If you can advance to the next slide.
Be happy to.
Thanks. Keep on going. There we go. Thanks. The nation really had, and just thanks to everybody for joining us, the nation really has become energized by this bold goal of achieving an 80% colon cancer screening rate by the end of 2018. And the question today is, what's it really going to take to achieve this goal next? So we've identified 10 steps to achieving the 80 by 18 goal, which have formed the framework for a larger strategic plan, which we will be publishing within a month or two. 1, we need to convene and educate clinicians and their organizations. There's still some uncertainty about screening guidelines and the right way to follow up on abnormal tests. 2, we need strategies to reach the newly insured Americans that have resulted from the Affordable Care Act. 3, we need to more effectively engage payers who are critical to our achieving this goal. 4, we need to find new ways to communicate with the insured unworried well, and I think we refined that message of what that really means to say, quote, unworried. Number 5, we need to increase access to colonoscopy for everyone. Next. Number 6, at the same time, we must ensure that everyone can be offered a stool blood test option, and we're going to focus on that today. 7, we need to really create powerful, reliable, committed medical neighborhoods that surround the federally qualified health centers and support the excellent work occurring there. But without a true medical neighborhood of GI, anesthesia, and hospital, the FQHC efforts are not sufficient. 8, we need as many partner organizations as we possibly can get. 9, we need to implement intensive efforts to reach low socioeconomic populations. And number 10, we need to really believe that we can achieve this goal. Next. So I'm just going to focus today on a few of the most critical of these messages as it relates to those individuals who have not been screened in this new communications toolkit. So first, let's talk about strategies to reach newly insured Americans. You know, this slide is now up to date. As of the end of this enrollment period, between Medicaid expansion and 2 years of enrollment through the exchanges, we're probably going to be up to about 17 or 18 million newly insured Americans. And we know that this skews a little bit older for those people who sign up, so there are lots of these folks who are now eligible for CRC screening and who did not have the opportunity to be screened because they did not have insurance, who now do. Next. So we're going to have to really work with payers to reach out to that group, and when I present that to payers, they nod. They do have the ability to find this newly insured group. So next, we have to more effectively engage the insured unworried well. We know that 75% of individuals who are not up to date actually have health insurance. We've learned that many of these individuals are just like the up-to-date group, but they tend to be less worried about colon cancer and less motivated to seek preventive health care. And the whole purpose of this toolkit is that we now have learned that we need different messages and strategies for this group. Next. We've learned that this group considers themselves healthy, but they're less likely to visit the doctor, talk about screening, or have a personal connection to cancer. they have the impression that if they don't have symptoms or a family history, they actually don't need to be screened, which, of course, is the antithesis of the whole concept of screening. And perhaps most concerning of all, they're actually less likely to be swayed by a doctor's recommendation. Next, all the more reason why we need some new messages. So here's what we've learned through this market research about the barriers to getting screened. And this is work that was done in over 2,000 people who were not up to date with screening. The number one barrier identified, particularly in the 50 to 64-year-old group in Hispanics, is affordability. I don't have health insurance and would not be able to afford this test, and I don't feel I need to have it done. Number two, lack of symptoms. Doctors are seen when the symptoms are evidently presumed, not before. And this was actually the number one reason cited in older individuals. So you already can get the idea of how to tailor your messaging. Number three, no family history. Never had any problems. My family had no problems, so felt it wasn't necessary. Next slide. Number four, perceptions about the unpleasantness of the test. I don't think it's a good idea to stick something where the sun don't shine, that yellow Gatorade I can't stomach, and other aspects of unpleasantness. Number five is interesting. The doctor did not recommend it. This was actually the number one reason among Black African Americans and number three among Hispanics. I fear it will be uncomfortable. My doctors never mentioned it, so I just let it go. And number six, the priority of other health issues. I just turned 50. I'm dealing with other health issues, so it's on the back burner. So that's what we've learned about barriers from our research. So let me focus on one of the other ones from the strategic plan, and that's the importance of ensuring that everyone can be offered a stool blood test option. Some people will not or cannot have a colonoscopy. Often availability, access, and affordability, and you saw affordability, number one barrier, make this very, very difficult. Our approach is that anyone who hesitates if you offer a colonoscopy should be offered a fecal immunochemical test or a high-sensitivity guaiac test, although I'll show you a little bit more about FIT. And so in some settings, and we have I'll show you some data about this, FIT needs to be offered as the primary screening strategy because that's the one that most people in that setting will do. Next. We now recommend that wherever possible, and we realize it's not uniformly possible in some settings because they have to pay for these tests, FIT should replace Hemoccult Sensa, which is a high-sensitivity guaiac test, because in a meta-analysis it shows better sensitivity and better specificity compared to Hemoccult Sensa, and there are now a number of trials showing that because you don't need to alter your diet, because you only need 1 or 2 specimens, not 3, that the return rate is better than FIT, which is perhaps even more important than this issue of sensitivity and specificity. Next. So wherever possible, FIT should replace guaiac FOBT. They're specific for colon blood, unaffected by diet or medication, and as I mentioned, some may improve participation in screening. Next slide. Here's a list of the FIT tests that are available in the United States. The PolyMedco product is the one that's actually been particularly well studied. Hemoccult ICT has some data, although I think not as popular. Ensure, very widely available. FitCheck, one that's particularly been well studied around the world. Next test. Next slide. Here's the bottom line of why this is so critical. Many patients prefer FOBT. In a diverse sample of 323 adults given detailed side-by-side description, 53% actually preferred FOBT, and many of them felt very strongly. Next. Similar trials in diverse settings, 212 patients at 4 health centers, 37% preferred colonoscopy, 31% preferred FOBT. In the VA setting, over 2,000 individuals, 37% colonoscopy, 30% FOBT. Next. But this is perhaps the most important trial of all. This is a randomized clinical trial in a public health setting in San Francisco comparing different recommendations for screening. If colonoscopy was recommended in the randomization, only 30% actually completed the test, whereas if FOBT was the recommended test, 67% actually completed it. So here's just the stark reality. Many patients may forego screening if they're not offered an alternative to colonoscopy, and that's why it's so critical that we offer both. We should not lose sight of the fact, and patients need to understand that anyone testing positive must then proceed to colonoscopy. A positive fit without a follow-up colonoscopy does not constitute completed screening. Next. One of the other factors in our strategic plan, the need to implement intensive efforts to reach the populations confronting the greatest barriers to care. Poverty, lack of insurance, low education level, lack of a regular source of primary care are all associated with very low screening levels, under 30%. 30% was actually the first, in 2012, that was the national rate for FQHCs reporting through the uniform data set. Many Native American tribes have very low screening rates, and some of these experience very high mortality rates. Next. So what's it really going to take to reach these groups? I think we need innovative ways that must be locally determined to support FQHCs, Indian Health Service, and other safety net practices. I think the best emerging models show that there must be some willingness to donate some services, particularly colonoscopy services, but it may be anesthesia and hospital services as well. One of the keys to making this feasible is to share the responsibility for donating services universally throughout a community so that a burden does not fall unevenly on just a few clinicians who quickly cannot handle that burden. Again, relying on FIT with colonoscopy only for people who test positive is a way to use those resources more judiciously. We've now, I believe, proven that for low-income communities, the patients facing the greatest barriers, communities or community health worker models with people recruited from these vulnerable communities absolutely do make a difference. So whatever model of navigator that can be used, you will see some increase in screening rate, and I believe that's a critical aspect of approaching this. Next. More and more organizations are signing this pledge, and if you've not read the pledge, I encourage you to do it, because what it really says is not just that we believe in the goal, but that we agree to dedicate our organization's resources to achieving this goal and making screening available for everybody. Next. So we've had an incredible group of organizations who've now signed the pledge. Here's the logos of many of them. Next. Still more who've signed our pledge. You may see your logo there. Next. And still more. So we need every health system, every comprehensive cancer center, every insurer, every hospital, and every practice group to make a commitment to get this done. They don't all have to sign a piece of paper, but we're not going to get to 80% for the whole nation unless we engage as many organizations around this goal as possible. Next. Finally, we must believe that this is achievable. We were able to increase screening rates about 20% from 2000 to 2010. We're now striving to accelerate that progress, achieving 15% increase in just 5 years. The problem with that, of course, is that we're now going after a more refractory group who's less interested in getting screened. So it's going to need some new communication and new strategies. Signing a pledge is not enough. We really need the organizations who sign and who don't sign to dedicate thought, time, and passion. Next. There are many important public health goals. We understand that, but we have a chance right now to do something remarkable if we pull together to do it. We can substantially reduce colon cancer as a major public health problem. As I say to everybody, let's get this one knocked out of the park, and then together we'll move on to the next goal. Next slide, final one. If 80% by 2018 is a slogan, we have no hope of achieving the goal. But if 80 by 18 is a call to action, it absolutely can be done. Thanks, Dave, and thanks for everybody for being on the call and for moving this important public health goal forward.
And thanks to you, Rich. Dr. Wender, for those outstanding comments. Dr. Wender really has an extraordinary understanding of the key issues here, and it's great to have him with us today. So we'll move on. Our next presenter will be Angela Hayes. Again, Angela is Managing Director of Mission Support Communications at American Cancer Society. And Angela will introduce the market research, basically tell us how it happened, what it showed, and then we'll introduce the resources that will advance the mission. So Angela, let's take it away.
Thank you, Dave. Can you hear me?
We can hear you nicely.
Great. First of all, I'd just like to say that I'm deeply honored to have the opportunity to really help advance this movement of reaching 80% colorectal screening rates by 2018. If we could go to slide 31. When we first started talking about this initiative, the American Cancer Society, one thing that we realized very early on is that this is not something that we were going to solve with a sexy advertising campaign. And through a series of discussions and planning and collaboration with the CDC and the Roundtable, we thought that where we could make the biggest impact is, one, to help people better understand, for us to better understand the unscreened community, and also to help our partners better understand the unscreened community, and to develop a set of messages and tools and resources that allowed us collectively to speak with one voice around the issue of colorectal cancer screening to this unscreened community. And so there are three phases of this that I kind of want to just walk you through today, and that will describe how we got there, what we've learned, and what we can do collaboratively in advancing this work and moving it forward. And one is getting targeted, understanding the market research, and two is getting integrated, looking at some of the ways that we can activate the entire ecosystem, and then to getting engaged. You'll hear from some of our partners about how they've taken this information and applied it to their existing campaigns. As Dave said in the very beginning, this body of work was not created to replace any group's existing campaigns or efforts, but to help enhance so that we speak with one voice. So moving to the next slide. As we got started, there are a few key threads, and Dr. Winder hit on some of these things that we learned very early on that emerged as key threads with the unscreened community. One, it was that awareness is pretty high about screening. It wasn't an issue of the unscreened community not knowing about testing, but we learned very early on that screening was just one of many issues. And as Dr. Winder also mentioned, colonoscopy for some is a barrier. There is a lot of fear related to the test in some of the populations, and so what we found that we needed to do was develop messages that helped to alleviate that barrier of fear. Another thing that emerged as a key thread is the fact that logical and rational messages were not compelling people to action. They know what to do, but just simply telling this unscreened community that they needed to act on the messages was not working for them. So if we go to the next slide, we really bucketed this into three big picture categories that we wanted to work collectively on in helping to shape our message. One, they're already knowledgeable, so we're not fighting a knowledge issue. That in order to break down the inertia and procrastination with the unscreened audience, we're really going to need to have a tailored approach for these communities. And number three, physicians continue to be the most trusted source of information, so our strategies really have to engage that very important influencer group in order to deliver the message. So if we go to the next slide. As we start to dig a little bit deeper into what the barriers are, there were some things that emerged as specific emotional barriers, like the unscreened community has this rationalized avoidance for avoiding the test. The lack of affordability, as Dr. Winder mentioned a little earlier, what is a really significant barrier for this community, and the negative connotations surrounding the test really were creating a barrier for being able to reach those procrastinators. And so as we were developing strategy and digging deeper to understand this community, we knew that we would have to be able to hit emotional drivers that counterbalanced all of the barriers that were presented by the unscreened community. We want to make sure that we maintain the success that we're having with the people that are already being compliant, but that we develop a set of messages that help present, that tap into the emotional drivers that we're going to counterbalance these things that are presenting as issues when we try to talk to the unscreened community. So if we go to the next slide, which I'll go through very quickly, one of the things that we found is that the core motivations on the left side of the screen, you'll see support and testimony, expectation, physical survival. Those are all things that we heard from the unscreened community that we were doing pretty well, but where we're sort of have been collectively missing the mark is on developing a greater sense of trust with the physicians, on developing messages that empower the unscreened community to have greater control over how they're screened. So if we go to the next slide, this work led us to develop the demographic profile and an emotional profile of what this unscreened community actually looks like. And within the toolkit, you'll be able to see these slides that go into a little bit more detail. The unscreened are typically 50 to 59 years old, more likely to be uninsured, more likely to earn less than $40,000 a year, more likely to be procrastinators. If we move to the next slide, and I'm going through these initial setup research slides pretty quickly because I want you to be able to hear from a partner that's taken this market research and actually been able to use it to influence some of the things that they're doing with their own campaign. This slide represents a very streamlined, high-level look at what the barriers, how best to communicate with the audience, and what channels are going to be most effective in reaching the key audiences that we're going to talk about a little bit later to actually move them to action. So you'll see here that the key thing that we want to address, for example, with the financially strained warriors is that there are alternative, cheaper tests available. If we go to the next slide, this is also just a demonstration, which is also in the toolkit, of each of the profiles of the unscreened community, the three that we've outlined. In addition, we have these more detailed profiles for the African American and Hispanic communities that give you specific psychographic insights for the audiences. And as I mentioned, some partners have already begun to take this information and apply it to the work that they currently have going on. One of those organizations is Chris for Life, and we're going to pause here in this presentation to hear from one of our partners that's been able to utilize this research in the development of their plan.
Thanks, Angela. That was terrific. And we'll come back to finish Angela's presentation in a moment, but we'd like to hear from Michael Sapienza, who's president and founder of Chris for Life Foundation. And this is basically going to be an example of taking the research and using it in what I would call real ways. So, Michael?
Great, David. Thank you so much, and thank you, Angela. So for those of you that haven't seen the Love Your Butt campaign, Dave, if we could go to the next slide, please. Thank you. We started this about 3 years ago in hopes really just to get general awareness for colorectal cancer out there. And we actually started it in Washington, D.C., Pittsburgh, and New York. And actually started a site along with it called the loveyourbutt.org site. And, that first year we were featured on NPR and decided, okay, so for the second year, how can we kind of dive a little bit deeper into this campaign and see how potentially, we can, reach other demographics, et cetera, through kind of more targeted campaigns. So next slide. So this is an example of our 2014 campaign, which we did in 8 different cities. So you can see the different ways that we did this. And what we kind of did new this year was also we partnered with a couple organizations on what we call a Find Your Doc app, or a web experience where patients or the lay community, I guess, from all over the country, say they were in New York City or wherever they were, could type in their zip code and find a GI doc in their neighborhood. And, after doing this, we did see some great metrics, but there wasn't really a way to kind of truly measure, what kind of difference is this actually having on us getting, quote unquote, to 80 by 18. So at our last meeting in July, I kind of took this to heart and really in our planning meetings decided for year 3 that we were going to take this one step further. So, I talked to Mary and Angela about potentially using some of the information that the ACS had done through their market research and utilizing that to help us do these campaigns in different cities. So next slide. So these are just mock-ups. We actually don't announce the campaign until March 1st, but what we're going to be doing this year is we'll actually be in 16 different cities across the country, plus online, and we're looking at different demographics. So for example, in Washington, D.C., we're going to be targeting the African-American community in wards 7 and 8. In Houston, we're going to be looking at the Hispanic community, et cetera, et cetera. We're partnering with C5, the New York City Health Department, in New York City on different demographics. And we're using a lot of the market research that Angela, Mary, and her team came up with. For example, you can see here we are using both the emotional driver, and you'll probably hear Angela talk about that more. We're not just showing quote-unquote butts, but you can see that there's some sort of emotion in the picture that kind of has people or draws them in to get checked. And then we're also using the colon cancer as the second leading cause of cancer-related death for both men and women. We're using that all over the campaign this year because through their research they found that in a lot of different demographics, so not just the uninsured African American or Hispanic, but almost across the board that was a really important one to use. So just to give you an idea of what we plan to do this year, we're actually going to be reaching individuals through TV, radio, print, online, transportation, and a social media campaign. And like I mentioned, we'll be doing this in 16 cities this year. So you can see here some of the cities and some of the demographics, et cetera, that we'll be reaching out to. And I just wanted to thank Mary and Angela for all the great work in ACS and NCCRT because we're really going to help us utilize that information. And one of the things that I didn't mention is we will be also doing focus groups in a number of these cities to see what is this target demographic know before, during, and after our campaign. So whether it's a month-long campaign or, as you can see here, we're also going to be doing some in the fall as well and see what they know.
So thank you, Michael. That was terrific, and that was our first example of how to use this market research and really sort of put it into real-world action. So let me return to Angela, who will complete her presentation. So Angela, back to you.
Thank you so much, and thank you, Michael, for demonstrating. It's just one example that you will hear today about how organizations that partners with the NCCRT are able to take this information and make it come to life through the campaigns and tactics and strategies that each organization already has going on. So, I like to tell this story about my children. I have 2 stepchildren that are pretty compliant, and when I think of them, I think of the early adopters with colorectal cancer screening. My stepson and my stepdaughter, they don't put up a lot of fight. And if you ask them to do something, they're going to be early adopters and do what you ask them to do. But I have a little sister, and she's 17, and I can't talk to her like I talk to the other children. What I learned very early on is that with that one child, I have to have very specific messages to be able to reach her, because what reaches her is not what works for the other 2. And such is the case with our unscreened community. After investing a tremendous amount of work into understanding the psychographics and the market research that you saw on the front end of this presentation, we took that information and put it into some very specific message testing that we did in partnership with the Public Awareness Task Force with NCCRT to understand what the specific messages are that are going to resonate with the unscreened community. And what you see here are the top 3 messages that we know resonate with that community, one of which ended up being breakout message, which was the option message. And when we looked into what it was about this option message that stood out, it really is about the control emotional driver. It's about having take-home options that allow you to the control of the privacy of your own home. So what we've done with the Communications Toolkit is presented these 3 messages along with the other. We tested 12 total, but the messages that tested most highly, and have taken within the toolkit these messages and presented what the emotional drivers are and suggestions for ways that you can integrate them into your specific campaign. So if we go to the next slide, again, this is activating the messages that we know motivate. There are a few things that all of our organizations can make sure that we do, because it's not just enough to deliver the messages that we're going to work. You know, we have to make the case for early detection. We have to focus on eliminating the real and perceived barriers. We have to work to align the systems to reinforce the messages, and also engage family and community networks. And all of those things being very important to motivating this unscreened community, because it takes an entire ecosystem to be able to move the marble with this. So if we go to the next slide, in addition to having the right messages, we also need to align with the right messengers. And what you'll find within the toolkit are some information, some additional information about not only the right messengers, but the right channels that each of these audiences responds most favorably to. Number one, and Dr. Winder mentioned this, but one that we heard over and over again, is that the physician really is one of the most trusted sources for colorectal cancer screening. So those things that we can do to work with physicians to encourage them to recommend screening, and making sure, though, steps that we can take to drive these 3 targeted communities to engage in dialogue with their physicians are very important to the success of 80 by 2018. Another thing that we heard from the market research that was really important, and I intended to mention this earlier, but one of the barriers with the unscreened community is that they have a low level of connectivity to anyone with cancer. So, having friends and family with cancer, it doesn't really resonate with them. So an important strategy for getting the right messenger would be to find those stories that make it really personal for the unscreened community and the people that we're trying to reach. And then also, when we're talking about engaging the right messenger, we can't underestimate the power of community organizations, nonprofit organizations, to help mobilize the message. So if we move to the next slide. This is, I got to tell y'all, this is like my favorite, of all the strategy work, this is like my favorite visual, just because I feel like it really demonstrates the complexity of what we're trying to do here in reaching 80% by 2018. We call it an eye chart, and so you see in the center there's the consumer. We have to take these messages and take these messengers and activate every single segment of this eye chart with the same message in order to begin to really break the ice and move the marble with the unscreened community. And you'll see that no one part of the eye chart is able to accomplish this alone. But if we are all utilizing the same messages, activating through every single part of the eye around the consumer, then what we create around this consumer, this unscreened consumer, is this bubble of consistent, persistent information that we know is resonating with them in the way that they need to be talked to. And that starts with caregivers, family and friends, leveraging earned and paid media. There are tools within the toolkit that address reaching out to media, payers and employers, advocacy groups, medical homes and neighborhoods. We want to take what we've created within the toolkit and activate those messages through every part of this eye chart so that we can move that consumer in the center. So if we move to the next slide. So what's in the guidebook? And who's it for? We talked a little bit about the 3 core communities that these tools are developed to help us reach: the financially challenged, newly insured, the insured procrastinators. If we move to the next slide, we'll start to talk about some of the tools that are actually included in the toolkit. So what you see here is pretty much the table of contents for the toolkit, determining the critical populations. We talk a little bit within the toolkit about current efforts to reach these target audiences. We go into much deeper detail about the specific messages and activating those messages across channels, which ties in the research that you saw in the first part of the presentation and brings it to life through the toolkit. And the next slide, I'll introduce to you a few of the tools specific to the guidebook. You heard Dave mention a little earlier, this is one of the infographics that we've created that's shareable across any organization. It's co-brandable, but there are 4 or 5 of these infographics that have the specific messages that we know will resonate. So the infographic information is available to you. It's also, these infographics have been turned into slides that we could share with our community clinic partners and doctors' offices within the medical community that they can run on their TVs. Additionally, the infographics could be shared with our other corporate partners, shared to all of our 80 by 18 partners, as well as other corporate partners that our organizations may have relationships with. In addition to that, there are web banners and social media messages, template press materials, all of which have been posted to the NCCRT website and are immediately available to you to begin using now. If we go to the next slide. So, we've talked at length about the market research and what went into developing and better understanding the unscreened community. We've talked about the messages that we know resonate and then what tools we have made available to activate those messages. And so at this part of the presentation, we want to just show some examples of how the work and research that we've done has been adopted and utilized by a couple of other organizations to amplify their existing campaigns. So, David,
thanks, Angela. That's terrific. One of the key things about the Communications Toolkit and the guidebook are real specifics, as Angela just said, that you can really use, like the infographics and the web banners and the social media messages. And Angela's demonstrated this really nicely, so thanks. I think you can really see how extraordinary this whole effort has been, how awesome the final product is, and how helpful it will be to use. So huge thanks to Angela and also to Mary Doroshank, Executive Director of NCRT, for all of the amazing work that's gone on. So let's get to those specific examples. Our first specific example is going to be presented by Angie Davis, who's president of Fight Colorectal Cancer, and as I said, the co-chair of the Public Awareness Task Force. Angie?
Hi, everyone. So I'm really excited to be a part of this committee and having seen this evolve over time and develop into a toolkit. At Fight Colorectal Cancer, we've been able to really be conscious now, hearing from Angela and hearing about the market research about our messaging around prevention, and specifically around the newly insured and the uninsured. And so for us, we've been able to adjust our language. And so that's what we've done. I think on the next slide they have a picture of our PSA that we'll be launching in March with Luke Perry. And for those of you who remember Luke Perry, he's turning 50, which ages me personally. I feel much older knowing that he's turning 50, but we're able to adjust his language to talk about, easy take-home options, and that's something that we've never done before. So I think what Angela has done in this toolkit has given us very concrete and specific examples of language that resonates with the population, that's based in concrete market research, and so it's been extremely helpful for us across our social media platforms, our videos, and messaging as we prepare for March.
So thanks, Angie. That was terrific. The next real-world example, if you will be Aubrey Van Kirk Villalobos, Director of the Comprehensive Cancer Control Group at George Washington Cancer Institute. Aubrey?
Thank you so much, Dr. Greenwald. Next slide, please. So, hi everyone. I just wanted to take a quick moment to share a highlight of our work at GW Cancer Institute in collaboration with ACS and the National Colorectal Cancer Roundtable. Through a cooperative agreement with the CDC that we have to provide technical assistance to comprehensive cancer control coalitions, we've developed a series of social media toolkits focused on various cancer awareness months. Each kit provides comp cancer practitioners with guidance on social media basics, best practices, and a tutorial on management using Hootsuite, as well as evaluation of reach and impact and sample posts and images that are easy to tailor and push out to their followers. We were fortunate this month to be able to use the 80% by 2018 Communications Guidebook when developing the messages for the Colorectal Cancer Toolkit to be released for use this March. On this slide, you can see here just a couple of snapshots from the inside of our toolkit and reusing a lot of CDC resources down there on the right-hand side in terms of videos and as well as the NCCRT infographics. Next slide, please. As an example of how we translated the research findings, you can see here on this slide the message that resonated most with all of the unscreened audience subgroups, that there are several screening options available, including simple take-home options, talk to your doctor about getting screened. For Twitter, you are probably familiar that the constraint for tweets is 140 characters. So we developed two messages from the original message that preserve that meaning, but also stay within the constraints. The first one is, there are several ways to get screened for hashtag colorectal cancer, including simple take-home options, talk to your doc about getting screened. And the second, colonoscopy isn't the only way to get hashtag colorectal cancer screening. Read more about your options and talk to your doctor with a link for more information. Using relevant hashtags helps broaden the reach of the messages because it can be discovered beyond those who follow you specifically. And so you can also see some Facebook messages that we developed here that are longer than the tweets, but should still be concise and clear. We try to include some sort of action item for the audience with each post, whether it's a link for more information, an actual command like talk to your doctor, or a call to share or repost the information. When available, we also try to link to lay-friendly media like YouTube videos, infographics, and photos that help drive the message home. So you can just see here, the middle example there says colonoscopy isn't the only way to get screened for colorectal cancer. Your doctor can even give you a kit for you to take home. Read more and talk to your doctor. And then the second one is a link to a podcast from the CDC director, Dr. Frieden, discussing colorectal cancer and the importance of finding it early. There are several life-saving screening options available, even at-home tests. Talk to your doctor for more information. Next slide, please. So thank you for the opportunity to share our work with you today and to be able to use that research early on in the development of this toolkit. For more about our technical assistance efforts, please visit cancercontroltap.org and follow us on Twitter for National Colorectal Cancer Awareness Month in March at GW Cancer Inst. And if you'd like to take a look at our social media toolkits, you can go to tinyurl.com/socialmediatoolkits. Back to Dr. Greenwald. Thank you.
Thanks, Aubrey. Great information, great examples. Thanks so much. So our final sort of real-world example, we will have Christy Marcel, who will talk to us about the Healthcare Service Corporation and the ACS partnership. Christy?
Thanks, Dave. Good afternoon, everybody. I serve as the Illinois Health Systems Manager for state-based in our Lakeshore Division of the American Cancer Society. As part of my role, I've had the great pleasure, along with several of my nationwide state health system colleagues, to work with Healthcare Service Corps. Next slide. For those that may not know, HCSC is the 4th largest health plan nationwide and includes Blue Cross Blue Shield of Illinois, Montana, Oklahoma, New Mexico, and Texas. Many of our Blue Cross partners across the 5 states have joined us for the webinar today, and we welcome them. HCSC and ACS are committed to working together in a meaningful way to increase screening rates in our states as part of the 80 by 2018 campaign. Next slide. We're really excited about the tools available today. I know you guys have heard a lot of great information, and I'm excited for you all to go to the link after today and really take the time to look through all the great tools that are on there. Just wanted to spend a few minutes today sharing how we have already begun to use them in our partnership. Healthcare Service Corps plans to utilize the research and tools to inform their colorectal cancer strategies. A starting point for us will be the working on co-branded patient reminders. HCSC already sends annual screening reminders and will be partnering with ACS this year to enhance the strategy. Our goal is simple, as stated in the welcome letter of the toolkit from Dr. Wender. How can we reach the unscreened in a more strategic way? Our American Cancer Society Healthcare Service Corps work group has already met to initially review the key findings and learn which key messages resonated the most with consumers. Some of these you've heard a lot about today already from previous speakers. So really, what are those key messages? What are those motivators? What are the emotional drivers that get people to get screened? What are those barriers, both real and perceived? These resources have really allowed us time for some meaningful dialogue with each other and to think strategically about how we can reach the unscreened and the newly insured. The populations we serve in our 5 states are diverse and present some unique opportunities for us as a collective team. So this makes our work more complex in our approach because the barriers and screening disparities look different state by state. This toolkit provides a great information on the need for tailoring messages as just one example, which Angela referred to earlier. We think this is an excellent resource for any health system or organization to utilize. It's really provided us a great roadmap to get started in our collaboration to really create the most effective messaging on our patient reminder project. And now I'd like to turn it back over to our moderator, Dave.
And thank you so much for that wonderful example as well. So the slide that's up now is an acknowledgement of the contributions of the many people who've gone into the creation of the toolkit, the resource book, and the presentation today. It's been absolutely an astounding effort, so we want to thank all of those people. We have time for a couple of questions that we've been taking online, so I'm going to actually ask some of the presenters to chime in as we go through those questions. But first I want to take a moment to thank each and every one of the presenters who just did an absolutely outstanding job in presenting this information, staying within the time limit. A couple of general things that I want to cover before we get to that. Again, we've recorded the webinar today, so the replay and the link to it will be shared with all of you. We will ask you for some help in evaluating the webinar. You will eventually receive an email with a survey link. Please help us by filling out that survey with very specific feedback. And finally, you'll be able to download all these tools that we've been talking about, find them at the NCCRT website, and use them in your colorectal cancer control efforts. We've gotten a number of questions during the webinar specifically about logistics like that. Most of them have been answered to you directly during the webinar, so you should have the answers. But the crux of them have been basically that the materials that we presented today have been recorded. They're available to you. The resources are available on the NCCRT website and on the individual websites of the specific presenters. So with that, I will ask, we did get one question which said, I'm wondering if we can use our connection with Stand Up to Cancer and ask those connected in Hollywood to incorporate colon cancer screening in their scripts for both TV and movies. And I'm wondering if any of the presenters has a comment on that.
Mary, do you want to take that? You want me to take it?
I think, sorry to pass the buck, either you or Rich probably work most with Stand Up to Cancer and might have a comment.
Yeah, I would just say that working with Hollywood is a very complex process, and we've had a great relationship with the Entertainment Industry Foundation. We hadn't specifically scoped out a strategy to do, well, what you're talking about is called content integration with shows. So we hadn't specifically talked to EIF about approaching any sort of content strategy with Hollywood specifically, but I think that's an idea to take back to them as a partner to see if there's something that we could do to bring that to life.
That's terrific. Thanks, Angela. We had another question that I think generically any of the presenters might be able to answer, which is what do we know about those who do not know much about colorectal cancer screening? I actually think the webinar was basically about that. Do we have any data on those who are not well aware of testing options, importance of prevention and early detection, and how do we tailor a message to move them to action? So very specifically, I mean, I think most of the webinar was designed to that, but if we had to summarize that in a couple of words, maybe Angela or Mary?
Yeah, I'll take that since I have been relatively quiet in this call. But really interesting, I'm not sure Angela shared this specific data point, but the number of folks who are familiar with specific colorectal cancer screening tests, the number who are aware of them is surprisingly high. It's like 93%. So the issue really is not one of general awareness. People, they know about the test. They sort of know they should be getting screened. But the challenge is, as Angela so beautifully presented, is that the logical messages that we've used in the past don't work with this audience. They do work with the folks that have been screening so far, and we need to keep that awareness high. But when we are targeting some of these hard-to-reach audiences, we do need to use these messages and deliver them in a more creative, more emotional way. I think one of the things that really was exciting to me is that these messages, they're just presented as words for the most part right now, but even as just these words, they almost doubled the intent of the unscreened to get screened. So it's very exciting for me to think about, what's going to happen when we deliver these words in a more emotional way and in a more creative way using the power of all the folks on the phone today. So I think that's where the real potential lies.
Thanks, Mary. We have a comment that asks about, have we reached out to the military health systems to come on board? I'm not sure the answer to that. Certainly a great idea. Any insight into that, panelists? Otherwise, it's a great idea.
We've go ahead.
No, go, Mary.
We've reached out to the VA a few times and have had the VA present. They have not at this point joined the roundtable, though we do have lines of communication open with them. But hopefully at some point they'll join some of our wonderful partners that are federal agencies such as Medicare, IHS, HRSA, CDC, of course, is a founding member of the roundtable. So yeah, I think we should continue to knock down that door.
And in a similar light, we have a question that says, have we reached out to the faith community? This one I actually know we've talked about.
I'll take this one. I think it's a great opportunity. The American Cancer Society is about to sign a major agreement with the African Methodist Episcopal Church, which is located throughout the nation. And part of our focus there will be around health messaging, and we have a faith-based tool there, and specifically the 80 by 18 campaign and the message about colon cancer screening. But I think more innovative options for working with faith-based community are a fantastic opportunity.
So with that, we've hit our 1 hour time limit. I want to again thank Dr. Wender, Angela Hayes, Mary Doroshank, and the other presenters today for absolutely outstanding presentations. I encourage all of you to spread the word about the 80 by 18 campaign, use the resources available to you, and I thank you very much for your attention to today's webinar. Thanks very much.
Yeah, thanks everyone. Wonderful to see such high-level participation. Much appreciated.